So good evening, everybody. Thank you so much for joining us tonight. I just wanted to go through a few housekeeping items before I introduce our speakers tonight. So I am Connie Sorman. I am the Senior Manager of Stewardship and Volunteer Engagement at the Children's Tumor Foundation. And I work on the NF2 Accelerator meetups and work with all of our NF2 accelerators. So I'm so happy to have everybody here tonight. We'll be telling you more about what being an NF2 accelerator means towards the end of the meeting. But we have some great content for you tonight, and we're really excited to share this with you. Just wanted to mention that closed captions are available by clicking the CC button at the bottom of your screen. We have a live captioner tonight. We're asking that everybody stay muted while our presenters are presenting, and then we'll have a Q&A at the end of each presentation. You can put your questions in the chat in the meantime if you think of them and you're afraid you'll lose them by the end. So feel free to post your questions in the chat. And when we do the Q&A, just use the raise your hand feature, which is in the reactions at the bottom of your screen, so that we don't have a bunch of people unmuting their mics at the same time. And then lastly, we have just a quick poll for everyone at the end of our meetup tonight. So that brings me to my introduction of Dr. Oliver Adanka, who's our honorary medical chair of the NF2 Accelerator program. Welcome, Dr. Adanka. Dr. Adanka works in the Department of Pediatric Otolaryngology, I hope I said that correctly, at Nationwide Children's Hospital in Columbus, Ohio. And he specializes in otology, neurotology, and lateral skull-based surgery, and is a champion of patients with NF2. So I will turn it over to Dr. Adanka.
Well, thanks, Connie. I'm also at Ohio State, which I would like to clarify that that's my main affiliation. So, but we are very delighted to have real experts today who have agreed to present it on both acoustic neuroma management as well as on auditory brainstem implants. Specifically, we have a team of both a neurotologist like myself as well as a neurosurgeon. So Dr. Friedman and Dr. Schwartz. Dr. Friedman is a neurotologist at UCSD. He's an expert on acoustic neuromas and related disorders. He's treated over 1,000 patients with this condition. His research on genetic hearing loss has received multiple times, in fact, NIH funding. Dr. Marc Schwartz is, again, a neurosurgeon. He's also an expert in the treatment of acoustic neuroma, skull-based tumors, NF2. Marc has treated over 2,000 patients with acoustic neuromas and is one of the leading surgeons in the field of auditory brainstem implants. I think Dr. Friedman will present on hearing preservation in the management of acoustic neuromas, and Dr. Schwartz will present on auditory brainstem implants. We do have some Q&A thereafter, so we plan on presenting for about 40 minutes, and we'll have about 10-15 minutes for discussion after the talk. So Rick and Marc, thanks so much for joining. I think it's so incredibly valuable to have your mentorship for us surgeons, for other surgeons, but as well as, of course, our patients. So appreciate you taking time out of your day to do this, and can't wait to hear what you have to say.
Thanks so much, Oliver and Connie, and thanks to the Children's Tumor Foundation. Yeah, Marc and I have been working together now for, I think, 17 years, and our practice is essentially all acoustic neuroma, meningioma, and we obviously have a special interest in NF2 and hearing. So I'm going to share my screen, and my topic is going to be hearing preservation and restoration and the management of acoustic neuroma in NF2. So there are some variables when we look at a patient's MRI scan who's presenting with the possibility of a surgical approach to removing the tumor to preserve hearing. There are 4 nerves in the internal auditory canal, 2 vestibular nerves, the superior and inferior nerve, and then there's the facial nerve and the cochlear nerve. So tumors on the superior nerve tend to have a better prognosis for hearing preservation, although in NF2, most surgeons agree that at the time of surgery, both nerves are taken, because if you leave one vestibular nerve, then the risk of another tumor forming on that nerve is relatively high. The extent of the tumor towards the cochlea. So if the tumor is impacted up against the base of the cochlea, and I think I have some images I can show you, then those are things we look for. That makes it a little harder. And of course, the size of the tumor. Tiny intracanalicular tumors, you know, I hear so often patients are told to wait and watch on a tiny little superior nerve tumor that's in the middle of the internal canal. And when you have the skill sets that we have and that Dr. Adunka and his colleagues have at Ohio State to do middle fossa, there's a real opportunity to save hearing long-term. So for tumors that are very small and in the canal and favorable, for example, upper balance nerve tumors, tumors that don't go up to the base of the cochlea and that are less than 1 centimeter, hearing preservation can be achieved in upwards of 80% for those cases. For tumors that are 2 centimeters and less, it's about 50%, but still a possibility. Here's a little bit about the anatomy of hearing. We have the outer ear where sound comes in and strikes the eardrum, moves the 3 little bones of hearing, sending a fluid wave to the inner ear and then an impulse to the brain. Obviously, what's affected in NF2 is the vestibular, primarily the vestibular nerve. It can be the cochlear nerve as well. In the case of a cochlear nerve neuroma, removing that would lead to deafness. So we would not do that and would never advocate that. But when they're on the vestibular nerve, it is possible to separate them from the cochlear nerve and preserve hearing. Let's see, there we go. So for anybody that's had an acoustic neuroma, anybody who is a family member of somebody with an acoustic neuroma or NF2, you all know that there are probably 3 strategies, really. I mean, 3 broad categories. One is watch and wait. And what happens to hearing when we watch and wait? There are some good studies that came out of Denmark that show that if hearing is really, really, really good on presentation, then it tends to last a fairly long time without intervention. However, if the patients present, which is most often the case, with hearing loss, then just by observing over time, hearing declines. And the reasons for that are not fully understood, but there's some work that was done by Konstantina Stankovic that shows that having the tumor in the internal auditory canal leads to the buildup of protein inside the cochlea, which is toxic to the sensory cells. So what I tell patients often is, even if your tumor does not grow, the likelihood that you're going to lose your hearing over time is substantial. The other option that I'm sure many of you have contemplated or been treated by, and that is radiosurgery. I have fairly strong feelings about radiosurgery in the setting of NF2. I think that the risks of malignant transformation are much higher, quoted by some as high as 4%. So I think it has to be used carefully and judiciously. But the other issue is that hearing preservation with radiosurgery has shown to be very poor in the long term. And more likely than not, it's a combination of radiation damage to the cochlea and the blood vessel, the tiny little blood vessel that supplies the cochlea, and the presence of the tumor leading to this protein buildup. We've shown fairly definitively, you can see the protein buildup on MRI scan, and we've shown in our practice pretty definitively that if we're able to remove the tumor and save hearing, that protein content goes down and disappears on MRI imaging after surgery. The natural history of radiotherapy, the history of radiotherapy versus natural history, you can see that this is a control ear, and this is fractionated stereotactic radiotherapy, which was really brought into the field with the hopes that by fractionating the radiation doses, we could preserve hearing over time. And unfortunately, it just has not panned out very well, and neither has the Gamma Knife for long-term hearing preservation. Hearing preservation for larger tumors, that's tough. When tumors are over, I would say that it's reasonable to be somewhat aggressive at trying to save hearing. If somebody's hearing is declining and a tumor is, say, 2.5 centimeters or less, but the likelihood of success when tumors are 2 centimeters and greater is pretty low, anywhere from 10 to 20%, which may be better than nothing if the hearing is on the decline. But the larger the tumor, the more difficult it is. But we still have some weapons in our armamentarium for preserving hearing for as long as possible. Medical therapy, chemotherapy is one, and Avastin has shown some promise. It's not a definitive answer, but I know that through funding through this organization, people are working diligently to find better ways of treating this. A surgical approach, though, is something called middle fossa decompression. So even for large tumors, what that operation consists of is opening the internal auditory canal by removing the bone and then opening the dura that covers the tumor and allowing the tumor to expand away from the internal auditory canal and the cochlear nerve. And there's good long-term data to show that in many cases, this can preserve hearing for a while. Now, obviously, if the tumor is aggressively growing, that creates problems for the patient, and large tumors that are growing, unfortunately, have to be removed. But if they're stable, even stable on Avastin in size, but hearing is declining, a decompression of the tumor could be helpful. Let's see, my computer is, okay. So how do we do it at UC San Diego? And obviously it has to be a person who's interested, right? We can't recommend this to everyone. This is a contract that's sort of made between surgeon and family and patient, of course. But if a patient has serviceable hearing and it's favorable, and they have hearing in both ears now, we would never recommend removing a tumor in an only hearing ear. But if someone has serviceable hearing in both sides, and the tumor is less than 1.5 centimeters, we would consider treating that patient with a middle fossa approach with a reasonably better than not chance of saving hearing. For 2 centimeters and greater, we use the retrosigmoid approach, and I'll explain why in just a few minutes. The advantage of the middle fossa approach is we have complete exposure of the internal auditory canal, and we can identify the facial nerve very early. So many of you out there may have heard from some surgeons who don't do the middle fossa approach that it's a risk for the facial nerve. In fact, it allows us to identify the facial nerve early. And so I consider it a safe approach for the facial nerve. And we're talking about tumors in this size range, small intracanalicular to just coming out of the internal auditory canal. But if they're touching the brainstem or very close, we would recommend a retrosigmoid approach. The advantages of the retrosigmoid approach for tumors that are extending out of the internal auditory canal, in our opinion, is it's safer for the facial nerve. If the tumor is touching the brainstem or part of the cerebellum, the middle fossa doesn't allow you to see the facial nerve close to the brain. And we then prefer to use the retrosigmoid approach. It just provides more room for moving the tumor around. And this is an example of a tumor that we might consider retrosigmoid. It's interfacing with the brainstem and goes into the internal auditory canal a bit of a distance. Long-term hearing preservation. So I asked this question many years ago: does surgery in and of itself, with the potential for scar tissue and things, lead to progressive hearing loss? And in fact, after middle fossa, and our colleague, Dr. Cueva here at Kaiser in San Diego has looked after retrosigmoid, that if you do save hearing, you save hearing for the long haul. Hearing preservation is lasting. Now, the one complication in patients with NF2 is no matter how thoroughly we're able to remove a vestibular schwannoma and preserve hearing, it's not uncommon for patients to develop facial nerve tumors and or cochlear neuromas. But I've been doing this since 1996, and I have a large group of patients now who we were able to save hearing through the middle fossa when they were young, and their hearing has remained for decades. So it is useful. It's a useful approach to preserving long-term hearing. And in our opinion, for small and really small to small, medium-sized tumors, it is the best way to save hearing for the long term. What happens if you lose your hearing? It's a possibility. And all of this discussion, there is the possibility of losing hearing. So that's why it's a conversation that has to be undertaken between qualified neurotologist and neurosurgeon and patient and family. If hearing is present, then a hearing aid or implantable hearing devices can be used. If hearing is not present, then the options are bone-anchored hearing aids, cochlear implants, or cross and bicross hearing aids, which reroute, aside from the cochlear implant, these devices reroute sound from the deaf side to the hearing side. So conventional hearing aids, if we're able to save serviceable hearing, it's wonderful. And sometimes patients will need, usually patients present with hearing loss that requires a hearing aid anyway. But if we can preserve serviceable hearing, then a hearing aid is useful. And that's a big win. Electrical and acoustical implants. So if we're able to preserve low frequency hearing, but word understanding and high frequency hearing are not ideal, there are electrical acoustical cochlear implant devices that stimulate both electrically and with a hearing aid component. And these have been shown to be quite beneficial for audiograms like this here on the right of the screen, where it shows pretty good low frequency hearing, but very poor high frequency hearing. For single-sided deafness, the cross and bicross hearing aids. So this is the hearing ear on the left in each patient. This is the unaidable ear on the right. So there's a microphone in the unaidable side that routes the sound wirelessly to the good ear. And the bicross just simply means that the patient also has hearing loss in the good ear. So that includes a hearing aid for that ear and a receiver for the cross device. Bone anchored hearing devices. Currently, there are a number of them actually. The Baja and the Ponto are the devices we use most often. Now we have implantable devices. The only problem with them is they have a magnet, and the magnet, as many of you know, creates tremendous artifact for MRI scans. So we don't use them very often in NF2. But bone anchored bone conduction, so the attenuation through the human skull is basically 0 decibels. So anything you put on the skull, you can hear in the cochlea that is remaining and functional. And then lastly, I think what's sort of coming online, not covered by many insurance carriers, certainly not here in California, is a cochlear implant for single-sided deafness. Now, in the routine patient, non-NF2 patient with single-sided deafness, I have a few of these patients, and I have to say they're happy. It's not a panacea for sure. However, if we fail to save hearing in a retrosigmoid or middle fossa, but feel that the cochlear nerve is in good shape, then that's also a huge win for patients with NF2, because they likely are cochlear implant candidates. And although the auditory brainstem implant, which Dr. Schwartz will talk to you about, that's his area of expertise, is a good device, it doesn't compare to the cochlear implant in most cases. So that's another reason why proactive management of smaller tumors, even if we can preserve the cochlear nerve in NF2, it's a positive. So in summary, and I want to leave time for Marc and I want to leave time for questions, early proactive management of vestibular schwannoma in NF2 can result in long-term hearing preservation, and is something that I feel very passionate about. I know Dr. Schwartz does. I am certain Dr. Adanka does, and something to consider. That's my little daughter a couple of years ago saying thank you.
Great, thank you.
Great talk, Rick. Yeah. I think we just reserve questions for the end, right?
We can do it either way. We can do it after each presentation or at the end. It might be easier to just take any questions that are available right now. I see one in the chat. Is there?
Yep.
Did you see it?
Yeah. Is there a minimal age limit for microsurgery? I am not sure on their sizes, but they do show up on MRIs for the past 1.5 years. So I don't believe there's a minimal age. I think the minimal age is, I don't think that we would approach a child that was in their early years and developing speech and language skills, but we have operated on children as young as 5 years old. A question about the characteristics of an NF2 vestibular schwannoma. If one's vestibular tumor that was already removed was supposedly not sticky at all and easily came off, what are the chances that the tumor on the other nerve will have the same characteristics, particularly where the remaining tumor is close in size? Yeah, that's a great question, and I don't know that it's ever been looked at directly. I would say these tumors, their growth certainly initiates, there's a primary genetic component, but there's also an environmental component. I don't think you can necessarily bank on one tumor on an opposite side behaving like the tumor, the prior tumor. I don't think that you can bank on that. I don't know how you feel about that, Oliver or Marc.
I would echo what you just said.
Yeah,
certainly wouldn't bank on that. Yeah.
Yeah, the genetics of each tumor in NF2, I mean, there's got to be 2 mutations, one of which is the genetic, is the inherited mutation, but the second one is a totally different mutation, so it doesn't have to be the same tumor.
Yeah.
Dr. Friedman said he would not recommend tumor removal for somebody with one-sided deafness. In that situation, how do you treat the tumor on the current hearing side? That's a great and difficult question. I would say that if somebody was losing their hearing and the tumor was growing or not growing, I would probably recommend a Avastin trial. If the Avastin failed, we could consider a middle fossa decompression, which we've done for single-sided deafness in an only hearing ear. And of course, there are people who say, I understand that this is my only hearing ear, but I also understand my best chance for preservation is while it's small. That's a contract that has to be discussed thoroughly between surgeon and patient to go for tumor removal in an only hearing ear. But in general, we tend to be more conservative. The other thing I would add is if the patient's an older patient with single-sided deafness and hearing is declining, in a case like that, I may not object to radiation and a cochlear implant on that side. I have a question. Is the translabyrinthine approach safer for a tumor over 3 centimeters if you want to save the facial nerve? So we would never do middle fossa for a 3-centimeter tumor. And we absolutely favor translab for tumors over 3 centimeters. We think it's just a safer operation for the cerebellum.
But there is an element of surgeon comfort about that. So each surgeon has a different experience. I don't think anybody doing just retrosigmoid, however, can. And this is only at the extreme, like really bad risk of complications. That's unlikely in either case with a good surgeon. I don't think they can match the complication rate of translabyrinthine surgery with retrosigmoid for the larger tumors.
Well, it looks like we can go to Dr. Schwartz and then people will probably collect more questions.
Can I share my screen? Do I have to ask permission for that?
Nope, you should be able to share.
Let's hope that it works. Oh, I don't know what I'm doing here.
Should be a little green box.
I'm getting
If you want, you can email me your.
I sent one in, but
Oh.
try this. Allow Zoom to share your screen. Open security and privacy, because this is a relatively new computer.
Oh boy.
There we go.
I think I have your slides as well.
Okay, that's fine. Yeah, if you want to put them on, and I can just say next.
Okay, let me just find it. Just give me 1 second. Here we are. Okay.
All right. And so I have to say next when we move on, right? So I'm going to be talking about auditory brainstem implants. Next. And to give credit, everything I talk about was really started by these two guys who were working in Los Angeles at the House Clinic. On the left is Dr. William House, who actually was the first one to conceive of and put in a cochlear implant, and sort of had all these ideas. And then on the right is Dr. William Hitzelberger, who's the neurosurgeon who actually placed the first device. Next slide. And what this is, as you think about it, how in a very general sense, how would we think about rehabilitating hearing for somebody who has hearing loss? For somebody who has has decreased hearing, hearing is what we think about first. There's some other, as Rick just talked about, there's some other devices that can be used. For somebody who's totally deaf, did that just disappear?
Yeah, not sure what happened. Hold on.
Oh, there we go. For somebody who's totally deaf, in a very general sense, most often the device is used as a cochlear implant, which is an implanted electrode array, and you can see it on the right side there in the cochlea, curling around with a bunch of electrodes that then stimulate the nerve in the cochlea, attached to a receiver that's placed under the scalp. And then there's an external transmitter that transmits to the receiver with a microphone on it and a computer processor that allows for noise to be translated into basically auditory stimulation. But especially when you're talking about larger tumors in NF2, and NF2 is actually the most common cause for this situation. The tumor takes the cochlear nerve with it. So the cochlea is disconnected from the brainstem, and so that's not going to work. And the auditory brainstem implant sort of bypasses the cochlear nerve and places that electrode array as a little paddle right on the surface of the brain, right overlying sort of the next step in the hearing signal going to the brain and all the way up to the cortex, which is kind of shown there, and stimulates directly the brain. You can do the next slide. And with NF2, going back to what this sort of looks like very generally, you have a patient with tumors, that those cochlear nerves are not going to go. And the whole idea initially was, well, we've taken the tumor out and we're just looking right at that part of the brainstem where the cochlear nucleus is. Why not just put the ABI in there while you're doing it? And and in talking to Dr. Hitzelberger, which I did many times, I don't think that they were expecting this to work, and they were kind of shocked when they put the first one in and it did work. Next. And this is sort of what's happened over time. So the first one that was put in was just some simple ball electrodes in 1979. They had a little laboratory in the building in the basement, and just made more and more. You can't do that anymore. It's not really what can happen in biomedical science anymore, to sort of go into the garage and build these things. Increasingly sophisticated devices. And then finally, a commercially available device that was created in a factory on the right there, which is what we've been using since 2000, which is a device from the Cochlear Corporation with 21 electrodes that's placed on the brainstem. Next. I think you understand. I think Rick also showed a picture of what this looks like in terms of the whole device on a person. So this is placed. There's some stimulation. People can hear things, but the question is, what can they hear, and how do you measure what they hear? And so, what are the goals? I mean, number one is, instead of being totally deaf, can you just hear environmental sounds? Hear a car horn or a dog barking or a doorbell ring? That's pretty basic, but still it connects people to their environments. And then, better, higher level than that is speech, understanding speech. And there's ways we measure how well this works. And sort of the two categories is closed set and open set. So closed set is presenting a word or sentence and having a multiple choice test of what the patient just heard. And then open set is doing the same thing without the multiple choice. So open set meaning it could be anything that was said. And then also measuring two things, and because I'll show you the results here, is using speech alone. So just the hearing, just the auditory stimulation, just the hearing, and then also adding the visual cues, adding watching somebody talk. So having the auditory stimulation augmenting lip reading, and lip reading is the main way that people who are deafened with NF2 communicate. Next. And so we would put these in, and these I'm going to show now what's kind of the classic results of these ABIs were, and this is actually the results that led to the FDA approving the ABI close to 20 years ago. So you put these in, give people a bunch of tests, and what happens? Here's the results of tests with this is just with hearing without lip reading, and the first four of these are closed set, and that's why you have that dashed line, and you can tell how many possibilities that they had. So there's a random chance of getting the question right, and then how much better do patients do, and they do a bit better. And then on the right side is an open set test, and that's not particularly good, but it's not zero. Next. But then if you add the lip reading, how do things help? And you're seeing the and this is sort of, I think, an important point. You're seeing in yellow what the sound is alone. In the dark blue is just lip reading, and the light sort of bluish gray is the ABI and lip reading together. And I think the most important differential you see here is on the far right of this, that in an open set test, which is at CUNY sentences, there's a pretty big jump from just lip reading to lip reading plus ABI. Next. And then the other point of this is, I mean, this is looking at individual patients. And so the light blue is just lip reading, and then the red is the lip reading plus ABI. Some patients on the left don't do very well at all, and other patients on the right do very well. And for instance, the best performer here is actually the fourth one from the right, where a patient did really poorly with just lip reading, but actually did great with lip reading plus vision to understand almost everything. Next. But this is just without the lip reading, just alone. And this is again the historic data going back 20 plus years, showing that the open set response is a sort of a minority of patients and a few patients who do quite well. So there's variable results, and the results I'd say are in this historic data set is it's certainly not perfect. It's relatively modest. A few people have great results, but most people have, I think, what you say is modest results. And there's a few people who don't have any results at all, who don't get a response. I will say though, in looking at patients who have ABIs and have no hearing, so there's two circumstances we place ABIs. So they've got no hearing and only the ABI. About 90% of patients use the ABI daily, so they don't just put it on the shelf and not use it. And just the data of showing the use of the device and how often it's used, shows that people are happy with it and they get benefit from it. Now we do take patients and we look at a patient and say, we're doing a tumor on the first side, and we know that there's a chance on the second side of not having hearing. Why don't we put the ABI on the first side, and while the patient still has hearing on the second side? and we call that a sleeper, that can be used down the road. Those don't get used very well, at least initially. There's a lot more data to show this, but I don't want to get too much into detail. Next slide. So how do we make this better? So that's the historic data. But the first thought was maybe the device isn't very good. The anatomy of the nucleus, which you can see on the left side here, the dorsal cochlear nucleus and the ventral cochlear nucleus, it's a three-dimensional structure that has depth to it. And so everything's not right at the surface. Why not place a penetrating electrode and this was developed in, close to 20 years ago, and there's a trial for this to stimulate directly at the different lamina, the different layers of the cochlear nucleus, and the results were not very good. And next slide, it really didn't work. It actually worked worse than the surface array. Why is that? I mean, I think about it. There was Stefan Rosal, who is a neurosurgeon in Germany, did a lot of anatomic studies of the brainstem in this area, looking at the cochlear nucleus complex. Next slide, and found that there's actually tremendous individual variation from patient to patient. So it's what you're looking at in one patient is not the same as the next patient. Everybody, just like people look differently, the shape of their brainstem is not everybody's is the same, and that's in patient and that's a cadaver study in people without tumors. And if you add a tumor to this that's distorted the brainstem and changed anatomy around, that makes it even more difficult. And so if you think about it, what was happening with that penetrating electrode was it was kind of like a sniper rifle with a really bad sight. And really what you need more is kind of a shotgun, excuse the gun analogy, I can't think of anything better, to sort of account for the differences in anatomy. Next. So what else after that? This is a picture of Professor Coletti in Italy. So we're talking about ABIs in NF2. Well, there's other causes of deafness and loss of the cochlear nerve without tumors, and he took patients to surgery just for placement of ABI. Now, it's not something that had first off, these are rare causes, very rare, rarer than NF2. But second off, we thought, well, these are kind of modest responses. And if you're in there taking a tumor out and put the ABI in as an add-on, that's great. If it doesn't work or work well, you haven't lost very much. We never really thought about bringing somebody to surgery just for doing an ABI. But he did that. And so you can see on the left in the black is the traditional NF2 patients with ABIs, and the red is the penetrating ABI, which didn't do very well at all. And the right is cochlear implants. So cochlear implants do much better. But he placed ABIs in these patients, and the green is what he saw. I mean, it's not perfect. Some patients, not everybody did great, but there was much better results. Why is that? Could it be some difference in the pathology, some difference in what's happening in the organization of the brain, some difference in dealing without a tumor there? Could be. Nobody really knows. Next slide. But then after that, there were these reports coming from Germany, and I have two people on the left, as Professor Baer and Professor Matthias, predominantly, who went back and we're starting to do in Germany ABIs in NF2 patients, and you can see in the sort of the purple there, the violet, we're finding results very comparable to Professor Coletti's results, and having very good results, better than anything had been seen before. Now we went back and analyzed our later data, and if you look at the blue, which is HEI, it says HEI NF2. That's not all of our patients, but if we took our 15 best patients and found that this is after the initial data that I showed you before, out of about 80 patients, our 15 best performers, we're doing about the same as the German performers, but that's a subset. So we have seen a great improvement compared to initial earlier data, but still, what's the difference? What are we doing better? What can we do better to have better results? We certainly see better results. But still, it's variable. So why are these patients doing well now that didn't before? What's the difference? Next slide. I mean, we don't. What are the possibilities? Well, number one is the device. I mean, we all in the United States use a cochlear device. In Germany, they're using a Med-L device. That's not approved by the FDA in the United States, nor will it be for financial reasons. Is that device a better device? I'm told by the Engineers, it's basically not, but could there be some unknown difference? Next, different surgery. We typically do translabyrinth surgery in a patient lying down. In Germany, they do a retrosigmoid surgery in a patient sitting up. Maybe that's a little different. Next, could it be the German language is easier? I don't, Oliver, maybe you have something to say that. I doubt it, but I mean, I'm thinking about all possibilities here. Well, a few years ago, next slide, we had a consensus conference to try to figure out what were the different reasons. And we didn't have an absolute answer. We presented all our data. We thought about what we do in the operating room. And I think that the consensus was that you have to be very careful with surgery. And just over time, people having more experience, being more careful with surgery, thinking about what you have to do around the brain if you're doing an ABI versus not doing an ABI. I mean, there's different things, there's a tolerance. By just being more careful and having more experience, you're likely to get better results. And I think that's borne out to a certain degree. Next, but there are challenges. So I talked a lot about surgery. I mean, what happens to a patient who gets an ABI? Well, first off, if you think about a cochlear implant, the organization of the cochlea goes from high tone to low tone, and you have electrodes that go in a line. You know what you can test, and everything works in order. When you do an ABI, it's much more complicated audiologic programming and testing. So you have to bring the patient back and spend a lot of time have an audiologist who spends a lot of time programming the device, and it changes over time, and the patient has to go back. Typical is every 3 months for 1 year, and then annually after that to get a sort of a tune-up because things change, and patients get better as they get used to it. They get better and better, but it takes a lot of effort and a lot of experience, not only in the operating room but also after that. I will say that with Avastin and especially Avastin, I think, but thinking about medical options for treatment, the numbers of cases have gone down. So we don't do as many as we used to because people are holding off longer, have more options for treatment. And the numbers of patients is not something which is done, in huge numbers. It's obviously NF2 is a rare disease, and patients who end up considering an ABI as a small portion of that. And so nobody, I think we've got the biggest program around in the United States, and one of the, but it's still not something we do every day. I mean, it's maybe 5 or 10 cases a year. That's not that many. And if you think about the geography, and how you set up centers for this, I mean, there's competing interests. You want to have surgeons getting experience in doing a lot of these, because I will tell you that when a surgeon does the first few of these, if it's the first few cases, they're not going to have good result. You need to get experience to get to be good at it and to have a chance of having a good result. But do you concentrate patients in fewer centers, which is great for results, but man, then you have, in the United States, people are really spread out. You've got patients that have to travel a long distances, and that's very different than Europe. Or do you have more centers all over the place doing fewer cases, and the surgeon doing 1 case a year is never going to get to be able to be good at doing it. It's a big challenge to figure out how to sort of, and then the healthcare system. And we have a very decentralized system here, we're not organized in the same way a lot of other countries are in terms of funneling patients. But these are the things we have to think about in doing these and setting up centers. We do have, if you are taking a relatively large tumor out or a large tumor out, and the size of the tumor until it gets to be very giant, there's not a real correlation between the tumor size and results. It seems to me like a very reasonable thing to place an ABI, but it's an effort, and it's not something that's simple and doesn't require keep up. I don't think that I have any more.
Great, thanks, Marc. Yeah, I don't know that the German language is different enough to warrant these different outcomes, but hey, who knows, right?
Yeah.
Okay, I haven't seen any questions in the chat, but yeah, certainly, you know, a comment that I've made in previous Zoom get-togethers is that a lot of ABIs patients I see at some point had bad surgery, right? And it's sort of to go back to what Rick said about going in early is not necessarily a bad thing, right? But doing the right thing is certainly you know, not very commonly done. So unfortunately we do see it a lot with folks who have NF2 that we'd like to make sure they get the proper tertiary care from experts like you guys.
Yeah, I mean, we all hate to say it because it's, you know, it sounds like we're being self-serving to say that, man,
Right.
patients need to get the places to do a lot of this sort of stuff. But it's true.
It really matters.
Yeah.
I think, you know, I hope the take home from today is that there is some hope for hearing in NF2. And I think the future is bright with organizations like the CTF. But what Oliver and Marc were just talking about, I cannot emphasize enough that there are few centers in the country with the expertise to manage this stuff. Unfortunately, that information isn't always provided when it should be. So ask a lot of questions, and it's about experience and training and skill set.
Yeah, and yeah, I mean, I haven't gone for several years, but I was because I mean, in full disclosure, I haven't been paid for them for years, for at least 5 or 6 years, but I never got paid a lot from them, very little. But I used to go to be the consultant for Cochlear Corporation for centers setting up ABI programs. And my advice was always choose your patient as a patient. If you're starting out as a surgeon, choose your patient, somebody who needs the tumor out, and think of the ABI as an add-on, especially at the beginning when you're doing your first few cases. Because if you've got the tumor needs to come out, no question about it, and you add the ABI, tumor surgery is successful and the ABI doesn't work very well, it's not the end of the world. It's just, I mean, it's sad. It's not a great result, but it's not the end of the world. But if you do surgery just for putting the ABI in, and that's the main purpose, and it doesn't work well, that's dreadful. That's kind of a disaster.
We have some more questions.
We do.
So I think one that I would like to highlight, sorry to interrupt you, Rick, was the
please.
one really, what would you recommend that patients asked in terms of the center, right? The topic we just talked about, right? I mean, what would you, both of you guys, really, what?
I think it's like Marc said, I don't want to sound self-serving, and I am from the bottom of my heart and sincerity, delighted that it's Oliver that's chairing that is chairing this session, because there are very few centers in the country with the experience to be doing this stuff. And it has to be a center that feels comfortable with all three approaches: translab, retrosigmoid, and middle fossa, if you're opting for surgery. It has to be a center that does a fair number. And I don't know what that fair number, I don't know what that number is. Maybe you guys want to comment, but I know if you're going to have an ABI placed, you want to go to a place that does it a lot, for sure.
Yeah, so, and none of us can guarantee anything. It's just a question of putting the odds in your favor.
Right.
And there's a big difference in odds. It's not a small difference.
And I would, what I tell patients always, right, is basically what Rick and Marc just said. I would say all approaches need to be available, right? They need to have all the pieces need to be in place, right? And there need to be a team, right? Like you guys work together for what you said before, 17 plus years, right? I mean, that's the kind of team you want, right? I mean, Marc and Rick can probably pick up whenever the other person is seeing something, right? I mean, and those are kind of things that really matter in the operating room when you're in there, right? Those 4 eyes are better than 2. And even in decision making, right? So I think it's complex enough. So you really want that well-oiled team, right?
Yeah.
I mean, that's...
Yeah. And I don't think there's a specific cutoff for number of cases, but it needs to be people that have done a fair number, done these on a regular basis. I mean, and And when you talk to a surgeon, I mean, you think about Malcolm Gladwell, so it talks about 10,000 hours. You talk to us, we've got 10,000 hours doing acoustic neuromas.
Right.
Yeah.
But we talk to, but if you talk to a brain tumor, just a brain tumor specialist, they're going to think they've got 10,000 hours, but that's 10,000 hours just doing all tumors, and that's not the same. If you talk to a general neurosurgeon, they've got their 10,000 hours, but that's just doing, neurosurgery or neurotology. That's not the same.
There's a really good question here about ways to enhance ABI performance. And I would say the best way to do that is to practice your lip reading. You can actually take lip reading classes. I think that would be very helpful for somebody who is totally dependent on an ABI. Mark, you were going to say something. Sorry.
Yeah. I don't. In terms of ABI, what enhances ABI performance? Being mindful, and it's if you're practicing violin or you're doing a sport, you're mindfully practicing and learning how to do it. You're gonna. That's what leads to success. And I hate to say it, but for an ABI, I think it's the same thing. I think that somebody who really is mindful about it and dedicated is. I don't know that we can say that we have no data to prove this, but the patient who is like, I'm going to take this as a challenge and I'm going to learn how to use this as well as possible. Now there's a luck aspect also. It's like, I wouldn't blame somebody who can't do it, because it is a part of luck, but really thinking this is a challenge that I'm going to have to work on is what leads to success.
One of the bottom question, what are the chances of recurrence of vestibular schwannoma if surgery is done on a very young child? So that's a good question. If the tumors are small, the likelihood of a recurrence of a vestibular schwannoma is low. However, as I mentioned earlier, depending upon the mutation, there can be tumors that develop on the facial and cochlear nerves that, are troubling. They're troubling, but as I've said, even with those developing, let me give you an example. When we do middle fossa, we open the internal auditory canal, we open the dura. So it is a decompression, if you will. We take the tumor out. When we save hearing, then we have a canal that's open, decompressed, and only has 2 nerves in it now. So even if there are tumors developing on the other nerves, we do see fairly long-term hearing preservation. There can be decline, but as I said, I have patients who went decades with hearing that was useful and or aidable. So the chances of recurrence, depend on the size of the vestibular schwannoma. For larger tumors, if they're very stuck to the facial nerve, we don't want to give anybody a facial paralysis. So we would do what's called a near total, which carries less than a 3% risk of ever recurring. But remember, there are other nerves in the canal that can develop tumors.
Yeah, it's definitely higher than in non-NF2 patients. And I think if you're saying a young child, which I think by definition means, a mutation that leads to having more than one tumor, lots of tumors, there's over time, there's going to be recurrences. It's not recurrence free. But we know the natural history of these tumors without treatment, and we know that we impact that natural history pretty significantly in the right direction, whether or not tumor occurs. What was my last point about that? Oh, and I mean, and we go in there sometimes, especially and we find a little tumor on the facial nerve, we find a little tumor on the cochlear nerve, and we can't take those out. We have to leave those.
Yeah.
And going back to the last question, I just want to mention one. This is my ultimate red flag and this is acoustic. I think it's probably less for NF2 than for sporadic, for regular sporadic acoustic neuromas. But if you see a surgeon who says, "Oh, we don't have to worry. It's going to be easy. We're going to just leave tumor on the facial nerve, and it's an easy operation these days because we know we can just debulk the tumor and radiate or watch it after that. No big deal." That's a red flag to me. I mean, you want surgeons who understand that this is not easy surgery. This is, even if you've done many of them, every case is different. Every case provides its own challenges. I always say that you can always talk about a surgery being easy in the past tense, but you can't talk about it easy in the future tense. Because you have to be prepared for everything, and you have to understand that the details are hard and the details are important.
Yeah. Another question about visualizing where it sits in relation to the facial nerve. When tumors are smaller, and we can see there's a space between the tumor and the brainstem, oftentimes we can trace the facial nerve on a high resolution scan. When the tumors are bigger and pushing into the brainstem, it's almost impossible to tell where the facial nerve is. Fortunately, over 90% of the time it's on the front or the front top of the tumor. But for larger tumors, you can't see. My son has bilateral VS, diagnosed at 8 with very little hearing loss. He's now 24. Wow. With only recent some more hearing loss in one ear, Avastin is starting to hurt kidneys. Wondering if we should just continue with wait and see, since hearing loss is so minimal. My opinion would be, if the tumors are growing, then you might want to consider a hearing preservation approach. If they're not growing and his hearing is stable, then I'd keep watching.
I think there's a question like that really depends on the specifics and exactly if how bad is the complications from Avastin. What are the sizes of the tumors? Are the tumors the same size? Is the tumor, is the side where the hearing is getting worse the same side as the bigger tumor, the smaller tumor? These are all things that we look at when we're deciding what to do.
Yeah.
I think there was one other question a little bit earlier on about tumors near the cochlea.
Oh yeah, I saw that.
From Lauren Gottlieb Mora. Did you see that one? Up at 7:45.
Yeah, 2.5 centimeters. Well, there's 2.5 centimeter tumors and there's 2.5 centimeter tumors. So if you think about a hot dog that's 2.5 centimeters long, that may be a hearing preservation candidate. But if you think about a meatball that's 2.5 centimeters in diameter, that's not going to be.
Yeah.
Yeah.
I would just, have a high volume center take a look at your films and give you some idea.
Yeah. That's a great point. The 2.5 centimeter tumors, right? They can be small tumors. Someone has quite a big head, right? But they can be quite big if.
Yeah, and it can be 2.5 centimeters in one dimension and 1 centimeter in the other dimensions, or it can be 2.5 centimeters around in a sphere.
Yeah.
That's tricky. I think a 4 centimeter tumor is always big, but a 2.5 centimeter tumor, right, can be both. Yeah.
And I think all of us would be more aggressive about trying to save hearing, even in medium-sized tumors in NF2, because the chance, even if it's small, it's not zero, and the chance to hit a home run is worth taking.
Yeah.
Looks like we have two minutes left.
Yeah, we have a few slides to go through to close out the meeting, but thank you all so much. This was really wonderful information. And we'll be sharing the recording with 125 people who registered for this event tonight. So,
Thank
you. A lot of people will get it.
Please seek out care at expert centers. Expert centers.
Great advice. Thank you.
Okay. Thank you all.
Thank you all.
Bye-bye.
All right. If we could get everybody to stay with us for just another minute or two. We have a few slides that we wanted to share from CTF. So let me get my screen shared. Nope. Oh, well. All right. First of all, this meeting is an NF2 meetup for the NF2 Accelerators group, which is Children Tumor Foundation's group of NF2 patients and patient advocates. And if you don't know anything about what an NF2 accelerator is or how to become one, that's what I'm here to tell you. You can email us at nf2@ctf.org and join our group. We have quite a few people who are helping us spread the word about what CTF is doing to further NF2 research and to raise awareness and mission critical funds. And then you'll get exclusive NF2 communications and opportunities like this meetup tonight. And then we have a calendar of NF2 meetups once every month. We have different topics, and they're all very well attended. So please give us, shoot us an email or let us know in the poll that you're interested in more information about that. Now, Michelle Prepisny, who's our Chief Advancement Officer, would like to tell you a little bit about World NF Awareness, or World NF Day Live. Are you here, Michelle?
I am, and I also know that Kim Robinson, who works hand in hand with me on this event, if she's on, she can also, I'd love her to join in adding anything about the May 17 event. So the World NF Day Live event is essentially our live stream event that we've done for the last 2 years, which hopefully many of you have been participating in. It started 2 years ago when COVID hit, and we wanted to find a way to bring everybody together to help make NF visible and to make you feel like you were seen and heard, and that we did. So we've done it in 2020 and 2021, and we'll do it again in 2022. It is a live stream telethon format. We have raised $600,000 over the last 2 years, and we're hoping to bring in somewhere between $300,000 and $500,000 with everybody who's watching and making a donation. We're really excited that this year we won't just be live streamed, but we will be live from LA with a small group of people, about 75 people in the room at the 3 Clubs LA, and that will be live streamed for everybody to watch and see, whether they're in their own home or at a watch party of their own. So we're really excited, as our headline performers this year are Rumor Willis. That's right, that is Bruce Willis's daughter, his oldest daughter. Rumor Willis will be our headliner, and Jim Ranger, who was a 2019 runner-up on The Voice, he will be our opening act. Jim Ranger also has 3 cousins who have NF, so he has been personally affected by this disease. Other celebrities include Jonathan Sadowski, who is our host, and we'll have celebrity shout outs and cameos from Ben Shankman, Chris Carmack, Mark Calavecchio, Paul Racy, who many of you might know from The Sound of Metal. We're very excited. He's also going to be a keynote speaker at our NF Summit, which Connie is going to talk about momentarily. Mark Feuerstein, Michael B. Silver, Roman Reigns, and many more to come. We'll also have mission moments from patients and NF families. So we're really excited. Again, our goal is 500,000. We hope that all of you will participate, and you can register. Please register at ctf.org/live. Kim, if you can put that into the chat, that would be great, because it's not on the slide. She did great. Thank you. Yep. So you can register, you can make a donation, and you'll get updates in terms of new talent that is participating. And you'll also be able to see just exactly how you can watch it on that day. If you want to host a watch party, get friends and family together in your home, let Kim Robinson know. You can email her directly at krobinson@ctf.org.
Wonderful. Thank you. So Michelle mentioned the NF Summit, which is coming up this summer, July 21st to the 24th in Chicago, Illinois. You can go to nfsummit.org for more information about that. But what it is it's a coming together of all of the people who have a stake in NF, whether you're a patient, a volunteer, a caregiver, a patient advocate, friend, supporter, clinician, everyone who has a connection to NF should be there. It's going to be a very powerful event with empowerment and education tracks and something for everyone. You'll be able to customize your own agenda to suit where you are in your NF journey or what your interests are. And you can register. The registration is open at nfsummit.org. If you have any questions at all, you can email me at csorman@ctf.org, and I'll put that in the chat as well. We have a quick poll, so let me do that right now. I'll stop sharing my screen. And all right, so the first question is, are you currently receiving communications from CTF for NF2 accelerators? So please go ahead and put your answers in. The second question is, are you interested in attending the NF Summit in Chicago, Illinois this summer? And based on your answers, I will get you some more information. And I don't think that I mentioned, because it is in here, that you can attend the NF Summit either in person or virtually. It's a completely hybrid event, and there will be, it'll be more virtually, it'll be more of an experience than just watching presentations online like you did tonight. You will be able to interact with other attendees and participate in contests and poster sessions and exhibition hall and all kinds of things. So it's going to be a very interactive experience. But of course, if you can get there live, please do. You won't regret it. There's nothing like being together with a whole bunch of people who are on the same journey that you are on. All right. Well, we've gotten most of our responses, so I'll end the poll and say good night to everybody. Thank you so much for joining us, and we'll be in touch. Good night, everybody.